So, welcome everybody. My name is Christian John Lillis. I'll stop my screen share for a minute so you can see me fully. And I'm delighted to welcome you to the last of the Peggy Lillis Foundation's webinars for 2021. And this tonight, our topic is C. diff and sepsis, and we're going to have a conversation with Dr. Vincent B. Young and also one of our advocates, Pam McCollister. I want to note that this webinar series has been generously supported by Ferring Pharmaceuticals. And so Dr. Young, if you don't know, is the recipient of Peggy Lillis Foundation's 2019 Innovator Award. So we're delighted to have him leading this webinar. So he was one of the last people we awarded in person before COVID has forced us to have two virtual galas. Excuse me. And so we will also have from one of our advocates, Pam, who lives in Oregon, and Pam battled C. diff for 18 months, starting in 2017, including a point where she was in septic shock. So a little bit of housekeeping. Pam is going to go first and present her story. And then if you have questions at that point, you can either put them in the chat or you can raise your hand using the Zoom raise hand function and we'll call on you. And then Dr. Young is going to present for about 20 minutes. And after that, we'll take another round of questions. We do want it to be a bit conversational and people to get a chance to ask questions and offer their own points. While everything Peggy Lillis Foundation does is pretty close to my heart, I've wanted to talk about this for a while, and I do talk about it when I do various public speaking engagements, but our mother, Peggy, who passed away from C. diff, what ultimately got her was sepsis. And I was somebody who I thought that I knew quite a bit about healthcare and what things looked like, and sadly came to learn out that, you know, somebody going into septic shock or going into sepsis can be sitting up, they can be talking, they can be walking. And so we think it's really important for people who care about C. diff to understand the proportion of C. diff patients who may be at risk for sepsis, what those signs look like, so we can be better advocates for ourselves and for each other. You know, it wasn't until we got to the hospital and mom was sitting up in her hospital bed that the doctors told us that she was going into septic shock. And I mean, I was stunned. Sorry, got a little emotional there for a second. So I'm very excited and pleased to be able to do this webinar. I'm very grateful to Dr. Young and to Pam for being here. And with that, I'm going to turn it over to Pam, and Pam's going to tell you about her experience with C. diff.
Okay. So my battle with C. diff began in the summer of 2017 from the overuse of antibiotics. It all stemmed from a back surgery that didn't go as planned, and that's an entirely different story. I was on clindamycin for a total of 40 days, and that was to ward off an infection. And little did I know that that would lead me down a path that I would end up fighting for my life. It all started with a trip to the emergency room that I thought was for complications that stemmed around my surgery. And it ended up being for something entirely different. I was eventually diagnosed with C. diff, something that I had never heard of, and something that was not explained to me once I was diagnosed. My family and I were left to basically fend for ourselves. Google was our search engine that led us to find out how to clean, how to care for keeping myself safe. I have 2 kids, and how to not spread it to my children or my husband. And as a mom of what were then fairly small kids, that was my main concern. Was it contagious? Could I still care for them the way that I had been? All of these questions that I had were not being answered. My second, third, and fourth recurrences of C. diff, I I became septic. And this again was something that I was not aware of, something that was new to me. I was sick. I knew I was sick, but I did not know that I was as sick as I was. I was admitted immediately to the ICU upon arriving to the emergency room all 3 times. I was in ICU for, I can't tell you how long, because I was in and out of consciousness on all 3 occasions. And I don't know if that was a mixture of medications and illness. I'm going to guess it was a mixture of all of it. I do remember at one point during my 3rd battle with sepsis, losing all hope, because there was nothing that was working to fight off the C. diff that I had just asked to end. I had asked the Lord to just end it for me, because I was done fighting. My body was weak. I could not go on anymore. And I remember that conversation with my husband, that I was done. I had gone through every antibiotic that they had for C. diff, and I had done a fecal matter transplant, and nothing was working. I finally was referred to an infectious disease doctor and given an infusion of Zinfava, which is what finally helped stop the C. diff from coming back. And that was after 5 bouts of becoming infected with C. diff. I won't say that my battle with C. diff is over. I have countless gastrointestinal issues still to this day. I have suffered post-sepsis syndrome. I have suffered medical PTSD, and it has taken me years to come to terms with any of it. I have met with nutritionists and have gone through changing my eating habits to regain the flora in my gut, to try to rebuild myself back to what I was. I will say, feeling 90% back to what I was before I became sick, but I still have that feeling deep down inside that I would think most people that have suffered through C. diff and sepsis multiple times will probably always have, like that feeling deep down that maybe it will come back. I don't know that that will ever go away, but I hope and pray that it won't. My goal in my recovery is that I can be the person for somebody to turn to when they are at their bottom. I wish that I had that when I was at my bottom, that my family had that I had the Peggy Lillis Foundation when I was sick to turn to for help, that we knew the signs to look for, that I knew what C. diff was. So my goal is to make it something that people know of, that people are aware of, that people know the side effects of taking antibiotics, that they know that they can speak up for themselves and know that they can too question, why am I taking this for so long? Why am I on this? Why are you putting me on this? And question doctors and know that they too can speak up for themselves, to just have a voice.
Well, thank you so much, Pam, for sharing. I know it's always hard to revisit our stories. I was getting really good at it, where like I didn't get that upset, and then when COVID happened, I found it harder to compose myself. I just think because we're all under so much stress. I do want to say Pam has been part of our Advocates Council for, I think, coming up on 2 years. And she really has been a wonderful resource to so many people across the country, reaching out to us, sharing her story, participating in our virtual summits. So, Pam, you really are doing what you set out to do, and we are super lucky to have you. And I don't think that people understand, something that I've come to understand in working with people that have post-sepsis is that if you survive sepsis, it is such an insult to the body that it takes, if you ever fully recover, it takes quite some time. And most people are not told that, up front, like that this is, you will have bad days. And, so if folks have any questions for Pam, feel free to electronically raise your hand or put some in the chat. If you would think about some later, Pam is going to stay with us, so you can ask them later. But we think it's always good to strike while the iron's hot. So let me see. It doesn't look like we have anybody. They're probably just all in awe of your tenacity, Pam. I know I am. If I get a cold, I can't get out of bed. So, and my husband's one that doesn't want to be bothered when he's sick, and I'm like, please take care of me. So, all right. So why don't we move ahead, and we'll have plenty of time for questions at the end. So I am very happy to introduce Dr. Vincent B. Young. Dr. Young is the William Henry Fitzbutler Collegiate Professor at the Department of Internal Medicine and Infectious Diseases at the University of Michigan. His interest in gut infections started back in medical school, and he has been researching them for many years. He's an accomplished researcher in the areas of C. diff and other GI infections. Dr. Young oversees the appropriately named Young Lab at the University of Michigan, which brings together students in infectious disease, internal medicine, microbiology, and immunology. He received his undergraduate degree from the Massachusetts Institute of Technology, where I did not go to school, and his MD, PhD from Stanford, where I also did not attend school. I went to Brooklyn College. So please join me in welcoming Dr. Vincent Young. Sorry, I'm a little goofy tonight, guys.
That's okay. Thanks, Christian. Thanks for the introduction. And Pam, thanks for your story. Before I begin, actually, I would like to ask you a question. Do you feel that while you were suffering through all of this, inpatient, outpatient, in and out of the ICU, did you feel that the physicians understood what your main questions were? And
No,
yeah, it
I
sounds
don't.
like from your story. And
Yeah, I don't feel like they fully listen either.
yeah, I mean, that's something that I do feel bad about when it comes to it. I was just talking to someone this afternoon about COVID because they had some interest in COVID and saying that, the physicians don't always tell us what's going on. And especially when it comes to diseases, and you guys are seeing the right screen, Christian? Yes? My slides are up properly. Yes?
No, I think you need to switch screens.
Oh, we have the wrong one. Here, let me.
Yeah, I think if you just swap displays, it should be.
Yeah, I'll just stop and I'll just, here we go. Is that better?
I think
No?
you need to reshare.
Oh, okay. Well, let's do this again, and I will do it the right way this time. I'd moved it over to the other screen just because I thought it would be kind of cool that way, but I'll do it the way that it worked last time. Here we go. How about now?
Nope.
And now.
Yes.
There we go. Got it. Finally. All the combinations thereof of swapping screens. Anyway.
Don't feel bad. I did an entire presentation that way, and people were texting me, and I was like, I'm speaking. Stop texting me.
Because you had the presenters display up all the time.
Exactly.
Yeah. Well, I don't actually use the presenters display, but it just comes up all the time. So I figure like, okay, whatever. I guess I could always mirror. Anyways, but thank you so much for the opportunity to talk about C. diff and sepsis. And when you have these talks and these webinars, you think, oh, they're bringing in quote unquote an expert. But let me let you in on a little bit of a secret that they always tell first year medical students and stuff like that. And this gave me a chance to kind of re-examine what I know, because they always say 50% of what we teach you in medical school over the next 5 years will be wrong or inaccurate. And the problem is we don't know which 50% is wrong. And that 50% is wrong within a couple of years. And so every couple of years, if 50% of what you're learning is wrong, by the time 10 years rolls by, you actually know nothing, right? So this gave me a chance to think about, I do study C. diff all the time. And as an infectious disease physician, I see patients with sepsis. But when I'm on the wards, I always tell my students and residents, I said, when I see a patient, I have to think of several things. A, what do I know? B, why do I think I know that? And C, probably most importantly, should I know that thing and for the same reasons? Because that's part of our continuing medical education. We're always making advances and we want to go forward. So I thank you for giving me the opportunity to kind of reinvestigate what I think I know about C. difficile and sepsis. And so let's start with sepsis. It's in the news all the time. And, September was Sepsis Awareness Month, and they're putting a lot of things. But if you read it in the popular press, you're not sure what it is. I mean, you can kind of hear like, oh, is it something that's, is this something that's just going to happen if I get a paper cut? I mean, that's what comes up in the tabloids sometimes. Is this something that's related to COVID? People started thinking a lot about sepsis with COVID because many of the patients who have COVID develop what's called sepsis. But what is it? It's a silent killer. But what is it really? Well, physicians often want to know what is sepsis. And we're constantly defining what all of these clinical syndromes are, including sepsis and septic shock. And if you look at this paper was published in JAMA, and if you look at the date, it was only published 5 years ago. You would think that physicians know what's going on by now. Shouldn't we know what sepsis is by now? Well, maybe not. Whoops, sorry, my chat popped up. Let me close this for a second. Can you see the chat screen on my display, or it didn't show up? We're okay?
No, you can't see it.
Okay, good. So, what is sepsis? If the doctors from 1 year ago can't figure out what it is, what's really going on here? Well, they do have a technical definition that came in this. I need to kind of hide the chat screen again. Sorry, it popped up and it won't move. Sorry about this. I'm going to escape, get out of this for just a moment. There you go. Sorry, I apologize for having moved. Good. All right. So what is the technical definition? They describe it, in doctor speak, life-threatening organ dysfunction caused by a dysregulated host response to infection. Okay. Even to physicians, that has a lot of vagueness to it. In this Sepsis 3 document, they did come up with a lay definition, which I think is helpful. And Pam, maybe this will resonate with you or not. I can ask you at the end. It's a life-threatening condition that arises when the body's response to an infection injures its own tissues and organs. And I think that is a fairly descriptive thing. First of all, it is life-threatening. And Pam's story really tells us about how life-threatening, how life-changing can be. It does arise in the setting of infection, and you're getting injury to your own body. And I think that's what's really, really critical. Let's talk a little bit about how common is sepsis. So this came out from the WHO last year. They published this report. And it's relatively sobering because it points out here that in 2017, there were 50 million cases nearly of sepsis worldwide, leading to 11 million deaths. And this is what made sort of the headlines in the tabloids, that 1/5 of all deaths in 2017 were related to sepsis. That's pretty sobering when you think about it. You know, 1/5 of the people in the world die of sepsis. And a lot of that occurs under children under the age of 5. 2.9 million of those deaths occurred. A lot of sepsis occurs in children. And there are regional disparities in sepsis because 85% of the sepsis cases in this WH study occurred in low and middle income countries. So that's something that we don't think about. We have very, very advanced healthcare, and we think that sepsis is something that's pretty rare. Well, what does it look like in the United States as opposed to worldwide, where it happens a lot in children? Sepsis arises more in the elderly in the United States and other more highly developed countries. In 2019, this is data from the CDC. It's patients who are 85 and older that had the majority of sepsis-related deaths, and men more than women at that point. So that's something to think about. So there's differences in what sepsis is. But what is sepsis particularly? I gave you that definition. I don't know if that really cleared it up for people. And I think the important thing is to know that sepsis is not a specific illness. Like C. difficile is an illness. We know what causes C. difficile, but sepsis itself fits into what physicians like to call a syndrome. And what's the difference between a syndrome and a disease? Well, a couple things. First of all, we really don't know what causes this. And again, this is the definition from Sepsis 3. By still uncertain pathobiology, we can't say that, C. difficile infection is caused by C. difficile that produces a toxin that does this particular molecular thing to your cells and destroys your intestine. Sepsis is not like that. And instead, what physicians do to classify someone as being septic and having sepsis, they look at a bunch of signs and symptoms on the patients. Clinical signs are things that the physician observes. Symptoms are something that the patient reports in a patient with a suspected infection. That's what sepsis is, okay? And because of that, they came up with this kind of algorithm for diagnosis sepsis. You have to have a patient with infection. And then they use these are what are called clinical tools. There's a complex version and there's a simple one. There's the quick SOFA and the SOFA score. And SOFA initially said for the sepsis organ failure assessment, that where that came on. Now it says sequential organ failure assessment. But you look at things, you look at how their lungs are going. They're looking how your mentation is. Is it affecting your central nervous system? How's your heart doing? How's your kidney doing? How's your liver doing? How's your blood, your blood clotting system working? And interestingly enough, they're able to distill it down into something that you can do quickly at the bedside. Is the patient breathing rapidly? Is the patient actually alert? Can the patient tell you where they are, who they are, or they have some degree of confusion? And is their blood pressure maintained? And if you look at this, this getting back to Christian's story, Peggy was able to sit up and talk, but was probably breathing fast, had a low blood pressure. But all of these things doesn't mean that you're in the intensive care unit hooked up to a bunch of tubes, as Christian had in his mind, the picture of someone who's septic. So that's sepsis. Really, it's based on how the person's body is functioning during the time that they have an infection. And the septic shock they focus really on the circulatory system. Can they maintain their blood pressure or not? And if you can't, then you're in what's called septic shock. And again, this is not necessarily important for you to think about, but to understand that even physicians have to take the whole picture. And it's not like you can do a single diagnostic test and say, yes, the person has sepsis. We have a test for C. diff. We don't have a test for sepsis. So let's go a little bit into why we think sepsis happened. Again, this is going back to this idea. The body's response to an infection injures its own tissues and organs. And you kind of think that's kind of odd. When we think about infections, we think about us being sick, and we get sick because something infected us. Some pathogen did something to us. The pathogen kind of produces something like a toxin or or something like that that damages us directly. And that's what causes our disease. And what we think is that we have an immune system that will hopefully clear out the pathogen to make us better and fight off the infection. And that's what happens. We are fighting the pathogens are trying to injure us. But in sepsis, we kind of go with something that is taught to us early in medical school. Some immune response is always good, but too much can be very bad. And what happens is that as we're trying to fight off these pathogens, as things get better, hopefully we tune down that immune response. But if we're unable to do that, and we're still not certain why this happens sometimes, what happens is that the inflammation and the immune response continues going unabated and eventually will start causing damage to ourselves, which is something to think about. It's not just that the pathogen's causing damage. In our immune system's attempt to fight away the pathogen, we start doing damage to our own organ systems. A lot of people here have thought a lot about C. difficile, so I won't go over this much. How does C. difficile happen? We have a normal, really complex community of bacteria in our guts that is able to do things like keep away pathogens like C. difficile, help us digest our food. But when we take antibiotics for whatever reason, we can inadvertently change the microbiota. In the case of C. difficile, it can the spores that are in the hospital germinate, start growing, produce the toxin, and that's what causes the disease. And we can give more antibiotics to try to treat it. And as Pam told us, sometimes that makes us better for a while, but even without any additional antibiotics, we can recur. And we think that's because our microbiota never return to their normal state. Let's talk about a little bit of the burden of C. difficile. This is from these numbers from the latest CDC update on healthcare-associated infections. C. diff is responsible still for a lot of disease, but over the past few years, we've been making a little bit of progress against hospital-associated C. diff, but not against community-acquired C. diff. About half the cases of C. diff seem to happen out in the community, not just in healthcare. And with sepsis, there's a greater burden of disease with the elderly. So let's think about what I've mentioned, the toxins from C. diff. Let's think about what that can do. So the toxin is produced by C. difficile in the intestine and can damage the intestinal lining. And whenever you have damage, the host responds by bringing in inflammatory cells to try to fight off the infection. And made me think a little bit more, well, can this toxin-mediated damage trigger sepsis in that particular case? So we're forced to reevaluate what is the relationship between C. diff and sepsis. If you talk to a lot of physicians, some physicians say it's kind of odd that sepsis doesn't arise in the setting of C. difficile infection all that often. It's very rare. Most people recover. I'm not really sure this is right, especially as we've redefined what sepsis really is, and we understand more about C. difficile. Maybe it is time to re-examine this relationship. So as I said, if you look at elderly adults, they're more likely to have C. diff than younger adults. And in this particular case, elderly was over 65. And children, the pediatric population, they might get C. difficile, but it's pretty rare. But if you look at mortality amongst the elderly, it's much higher than it is in adults and certainly in the pediatric population. And in this particular paper that came out a few years ago, they said, septicemia and renal failure, pneumonia, and urinary tract infection were the most common causes of mortality in the patients with C. difficile. And that made me think, sepsis and acute renal failure is actually part of sepsis, and lung failure can be part of it. So really, a lot of this could be attributed to be sort of sepsis. There's another paper that came out last year, and in all of this, they again showed that age was a predictor for mortality. And also having inflammation, this C-reactive protein, is a way that we can say, there's inflammation going on. Both of those increase the risk of mortality in patients with C. difficile infection. And if a doctor actually put the diagnosis of sepsis in the chart, that increased the risk of death fourfold. So what's really going on? That was a single site. I know a lot of the people here, there are C. diff researchers here. They did a multi-center study in Europe. And again, they looked at 90-day mortality in 624 patients who had C. diff. And in this study, and this is not unusual, and they didn't really select the sickest of the sick, 415 of these patients had died within 90 days after their diagnosis of C. difficile. And again, these are hospitalized patients. But again, they show organ failure, pneumonia, and sepsis. Well, organ failure is part of sepsis. And if you look at what's going on here, high white count, inflammation, all of these things, the cognitive impairment, that was one of the highest predictors of mortality. These are all things that are included in the revamped sepsis definition. So really, again, I mentioned the SOFA score before, but it really is looking at all the organ systems, and all of these organ systems in this study can be affected by C. difficile infection. So maybe we're just sort of under classifying patients with C. difficile as having sepsis. A lot of the patients we know of who are sick from C. difficile and eventually do recover, we can actually come up with some of these categories that would actually classify them as having sepsis. So what is this link then? What could be going on? What could the link be that is mediated between C. difficile infection and sepsis? And we've talked a lot about the microbiome in the setting of C. difficile infection, but a lot of people, and some of my friends and colleagues are on these papers, are saying, well, wait a minute, the gut microbiome actually plays a role in sepsis. And perhaps this is the link that we see between patients with C. difficile infection and sepsis. And from this paper here, they kind of come up with this idea that if you disrupt the normal microbiota, this can lead to all sorts of things going on. You can kind of release some of the bad bugs that are in the gut from suppression. They start growing up. You change immune responses. You decrease some of the beneficial things that your microbiota produces, like short chain fatty acids and bile acids. And this can lead to sepsis, which causes all of the organ failure that we see. And when I saw this coming out, I was kind of chuckling because I was coming up with a figure on the role of the microbiota in C. difficile. And I looked at it and I hadn't peeked it there. Same thing. Look, we picked the same sort of metabolites. We picked immune responses, and we kind of brought in all of this as part of the pathogenesis of C. difficile. And the fact that we're all thinking about this the same way, and I brought this up to one of my colleagues, maybe it's time for us to look a little bit closer at how the microbiota not just influences C. difficile and sepsis, but really can this link C. difficile and the sepsis that we see in our patients. So I'd like to stop there because I'm never sure if, especially when I'm talking to a mixed audience, did I raise more questions than I answered by that? So I just like to stop by acknowledging all my friends and collaborators who have helped me out over the years to study C. difficile infection and to help take care of patients in the hospital. So be happy to take any questions at this time. And Christian, you made a comment about that. There's the picture of Salvador Dali that I kind of knocked off my own picture of me and my cat about. So anyways, I'll stop sharing and happy to take any questions at this point.
Well, that was really great, Dr. Young. I'm trying to force myself to not call you Vince when we're doing
No,
this.
Vince works. Vince, we're on Zoom. I'm Vince. Come on.
It's like weird when you know somebody and then you're in like this thing, you're like, yeah, Dr. Young. I must be like, my father-in-law is Dr. Young. He's an retired ophthalmologist. So if folks have questions, do feel free to raise your hand or put them into the chat. I actually had one for you, which was, do you have a sense of what explains the gender and age disparities in terms of sepsis that you were referring to earlier? The age makes sense to me, but the gender one I thought was a little odd.
The gender one is a little different, but when we write grants and we write grants to the NIH, we've many times ignored sex as a variable. I mean, physiology of men and women is quite different in more than just the obvious ways that we think about. And that extends to how the immune system works. That's something that's interesting about sepsis and C. difficile. C. difficile has a slight predominance of incidence in women, not much. Whereas, as I mentioned, sepsis and sepsis mortality is higher in men. And we certainly have seen that in the past 2 years in the setting of COVID, right? More men than women infected with COVID have had problems with, surviving COVID infection. And we're just beginning to figure that out, and that the immune response to a given insult is different in men and women. And since, as I hopefully told people a little bit, it's the body's immune response supposedly against a pathogen, but that eventually hurts ourselves. If there's a difference in how strong the immune response is in men and women, that could also lead to a difference in sepsis itself and the mortality of sepsis. Yeah.
Are there?
Go ahead.
Go ahead. I was going to say, are you? Is there any? So, with C. diff, there's been some good studies that have shown that there is slightly more. I mean, percentage wise, I don't know the numbers in front of me, but on average, white people get C. diff more than people of color, particularly Black people. But Black people tend to have worse outcomes.
Yeah.
And so for me, my suspicion there is that is sort of society. White people are more likely to have access to healthcare and therefore be more exposed to antibiotics and more exposed to C. diff. So we're going to have a slightly more prevalence there. But then again, people of color, once they're sick, may not have as good of insurance, may not have access to the best medical care, so they're going to have a worse outcome. And so I'm wondering if you see any racial disparities in terms of sepsis.
There is definitely in terms of sepsis. And one of the predictors of sepsis are comorbidities. And again, this is related to access to healthy foods. And I think there's higher rates of obesity, diabetes. And again, we're seeing that in the COVID, when people are trying to unpack, why is there increased mortality amongst people of color who have COVID? Is that because the predictors of worse outcome, diabetes and obesity, are more prevalent? And why are they more prevalent? Is it because of the lack of access to healthy food, lack of access to healthcare, et cetera? And as you point out, one of the downsides of good access to healthcare is you probably get more antibiotics, which can make it more likely that you will get C. difficile. So yeah, all of these things are very difficult to unpack because they're all, from my statistician friends, they're all confounded. There are a lot of things that vary together, and it's kind of hard to look at what just happened, what's really causing what, and what's associated with something else for all sorts of other reasons.
It was a really remarkable moment early. And I do have another question about C. diff, but this is something that I think is worth bringing up because it's about the disparities, which is, you may have heard of Elmhurst Hospital here in New York because it was one of the first ones that was completely overrun by COVID. And one of the shocking things that they were able to discern later on was that if you looked at the path of the J train, which ends at Elmhurst, the infection rate among the people that access the J train was much, much higher than any place else in the city. As a result, also the MTA workers who worked on the J train line were also much more likely to get COVID and die. And I think it's because this is a train that goes through some of the poorest parts of our city, people who are, working jobs that they couldn't take off. They couldn't, work from home like I have and many other people have. And so I do think, when we talk about C. diff and COVID has made this even more clear to us, is like, this is a societal problem. Like as much as we're excited for new treatments, we're excited for new diagnostics, like at its base, we have to care that like hospitals are clean, people have good, healthy food, they have strong microbiomes, they're not receiving unnecessary antibiotics. Like it's really an all hands on deck situation. So another question I had was, as I mentioned earlier, like we didn't really know what sepsis looked like, especially early on in it with my mom. If someone or a loved one has C. diff, what are the symptoms that they should be looking for, to kind of clue them in that maybe this person is taking a turn and they should get to the hospital or act more quickly?
Well, there are a number of, again, physicians like to have scoring schemes to say, oh, well, who's having severe C. diff? And if you look at some of them aren't necessarily well validated, but my society, the Infectious Diseases Society of America, they have a fairly simple scheme, but it makes sense from what we talk about with sepsis. If your white count is above 25,000 per cubic millimeter, or if you have a change in your kidney function, it gets worse by something that we measure called the creatinine. If it's above 1.5, if we don't know it, or if it increases by 1.5 fold over what your baseline is. And again, those are two of the things that we see with sepsis, right? You're having signs of increased inflammation and one of your organ systems is being affected, your kidneys in this particular case. And when I talked about that Q-SOFA, the other one that you can also see is the person's breathing fast. They're having a hard time breathing. That's an indicator of a lot of things, not just pneumonia. They might be not having enough blood flow through their whole body. So they collect acid. And one of the things you do when you have acid, you breathe faster because you're trying to blow it out, because you can blow out CO2, which is technically the same thing as acid in your blood. And then if you're not thinking clearly, and you always talk, hey, Mr. So-and-so, Mrs. So-and-so, how are you feeling today? And if they can't even tell you where they are, that's something, another sign. So I think that we have made physicians more aware of this. And during Sepsis Awareness Month, all of those signs that you could say, oh, the person's just sick. Well, actually, it's not just sick. You shouldn't be becoming more foggy. You shouldn't be breathing so rapidly, etc. So I think there's a lot of things that you can have as simple signs that you can assess that, well, something's not right. And I think you saw that. This isn't how mom was, right? This is not what goes on.
No, I mean, we chalked it up. And, if I knew then what I know now, et cetera, we might not be having this webinar, but, she was a very robust person. And when I got there, she seemed very sluggish, but, we did at that point know that she was on her, her fourth day of diarrhea. And so my assumption, like what I was chalking everything up to was dehydration. Mm-hmm. Which, can cause sluggishness, disorientation, she was actually fairly sharp, all things considered. But, you mentioned earlier the white blood cell count of 25,000. So when we got to the hospital, my mother's white cell count was 40,000. Mm-hmm. And even when we called the ambulance for her, when they got there, the EMTs, her blood pressure was 70/50.
Yeah, so it's low.
And they called
sepsis right there.
Yeah. They called for an ambulance, that had resuscitation equipment because they were afraid she could code. I don't think people understand, like when your blood pressure is that low, like your heart can just stop beating. Like you don't have enough volume. And so these are certain things that I think, if people know how to take a basic blood pressure, like these are things that they could teach themselves to be able to assess somebody who has any sort of infection as to whether or not, my husband makes fun of me because if he's sick, I'm always like taking his temperature with my hand.
but the key thing that,
I can't help it.
One of the things that we say is the easiest way to assess if a person has a good blood pressure is talk to them.
Right.
Because one of the first things that happens when your blood pressure goes down, it doesn't matter. Someone might have a blood pressure of 70, but as long as everything's fine up here and it's pumping enough blood to here to keep your mentation going, then okay, that's adequate. You don't actually have to know what it is. But if all of a sudden someone who's normally quite together can't remember where they are or seems confused, is not certain what's going on, you should be concerned because that's a sign of a lot of things.
Yeah. There are certain things that, you should just kind of get have somebody evaluated if they seem confused, if they are breathing rapidly, if they, like there's a number. That was something that we did notice with my mom, is that she was having trouble catching her breath. That was the first thing. But again, I thought dehydration, so we don't have any other questions. Maybe we're going to get out of this a few minutes early. Oh, wait, hold on a second. Oh, it's just an incredibly kind remark for Pam. Pam, do you have any questions for Dr. Young before we wrap it up here?
I don't. Yeah,
I think that your story, you've had C. diff more recently, right? I think already there, you were treated differently than Peggy would have been treated. You were able to get this monoclonal antibody, bezlotoxumab, right? That was
yeah,
Yeah.
directed against the C. difficile toxin that didn't exist, unfortunately, before. And that was able to break that cycle of recurrence. You did have an attempt at what we thought was one of the other ways to break recurrence, which is the fecal microbiota transplant. But unfortunately, for whatever reason, that didn't work. So it gets
Yeah,
back to the story that I said, is that as physicians, we have to continue trying to learn and understand what other people are doing and how does that apply to the patients that we're taking care of. And hopefully for Juan, who just chimed in here, that is some currently fighting C. diff, is that the physicians hopefully think about both sepsis and C. diff differently now in a way that they can keep him safe.
yeah,
Yeah, I would say, take your temperature. I mean, one of the things that they say with sepsis is that if you start to feel like you start to feel really bad, really like almost a sudden onset of like, they feel like it's like a fear of impending death almost, like
Oh yeah.
you should talk to somebody, because that is something that, oh, Lynn has a question. Have you seen any
Yeah.
cases of C. diff? Okay, go ahead.
Yeah. So the whole idea of probiotics and C. difficile, it's still under investigation. At first, a few years ago, I was pretty skeptical about probiotics, but now there have been more studies, and particularly what are called meta-analyses, where we look at a number of studies. I think what happens is that we didn't know enough. The idea of what is a probiotic, well, even that, again, getting to the idea of what is something, is all yogurt probiotic? Are all bacteria that are in yogurt probiotic? How many do you have to take? So getting specifically to that question, I have seen patients who've come in with fulminant C. diff, and they were trying to prevent it by, while they were on antibiotics, taking a probiotic. One of the things that you can see in septic patients is you can grow a bacteria out of the blood. I've never grown lactobacillus, which is one of the common probiotics, out of the blood of a patient who's septic with C. difficile infection. But there are case reports where it's happened. So I can't say that it's not a risk to take probiotics, but I think it's mostly we don't know. That's something that we're trying to investigate. A number of people are looking at how can we reinforce our microbiota by giving back drugs. The sponsors of this webinar, Ferring, that's one of their areas, is how do we give bugs as a therapy? But we don't know yet, I think. And I know a lot of people are impatient. Can't we figure this out by now? And I would have liked to think that after the amount of time we've been studying that we'd be a little bit further along than we are. But at the same time, I think we're making important advances, and hopefully we will make very sudden advances. Yeah, research takes time. But when research has done enough that we are in the right position, myself, I'm coming up on the year anniversary of getting my COVID vaccine. And when people started talking about vaccines at the beginning of the pandemic, I was like, oh, come on, but I was amazed that in less than a year, because of the years of research we had done before, this is not something that was just made up out of whole cloth, because people had done a lot of research. We were in the position when we were pushed to that point. And the only thing that was really limiting us was sort of money and manpower. And we threw that all behind it. If we had thrown that kind of money and manpower behind it, and we hadn't had the decades of research to get us to that point, we wouldn't have succeeded. But I think what it is, we leveraged all that research that we had.
So I want to make a comment about that in general, Vince, before we go on to this next question, which is for everyone who's listening to this website or watches the recording of it, take a look, investigate, pre-COVID in particular, how much money went into research for infectious diseases versus cancer or heart disease. Infectious diseases get a fraction of the amount of money as chronic conditions. And so that's something that, as you said, because of SARS and MERS and so these other coronavirus things that really didn't touch the US, but were huge problems in Asia and the Middle East, there was a huge body of research that could be taken on, and got us these vaccines relatively quickly. But it's slow going, mainly because there just isn't the investment in the manpower in infectious diseases. Like, look at how quickly now I think Pfizer got approval, and I think Merck is seeking approval for these COVID viral antiviral drugs. When was the last time we came up with an antiviral drug? I mean, like, just we don't have the kind of citizen pressure on the government that we do around chronic conditions, and we need it. And that's something that we're trying to do here, is to, because we need to get that federal money into more labs like yours, into more phase 1 clinical trials, so that we can, develop more and more treatments. So anyway,
Quote a phrase from your lips to the NIH's ears. But
I'm telling you, you should have heard me at my board meeting the night. I was like, we got to start lobbying the NIH. They ain't giving enough money.
I think they are, and I think that there's not an infinite amount of money, and I think they are putting more money into things. If you look, the National Institutes of Allergy and Infectious Diseases has earmarked some research money specifically for antibiotic associated infections, C. diff in particular as well. So I think it comes up as they have to kind of balance with how much money they have and where the pressing needs are. And I think that the things that organizations like the Peggy Lillis Foundation are doing are essential to kind of raise that awareness, so that people will talk to the congressman, so that they understand. It's one thing if the NIH understands, but ultimately it's Congress that passes the
there's
budget.
money that gets allocated, and there's some wiggle room at NIH, but they have to kind of abide by what Congress has appropriated. So Holly had a question here.
Yeah, and the question is, what do you recommend for patients who don't present with the typical symptoms of C. diff to get diagnosed and treated properly? That's kind of a tricky question in general about people who have an illness that doesn't fit into anything. How does that go forward? If the person is having some sort of gastrointestinal symptoms that may not be classic for C. diff, but could be an infection, physicians will sometimes send these kind of panels of which C. diff is included to try to diagnose, is this related to an infection or not? And it may come up that way. But that's kind of more specific advice that I'd want to give, as opposed to the more general advice, is work with your physicians, and hopefully you have a good relationship with, in particular, a primary care physician, someone who knows you, knows what your baseline health is. I think that's one of the problems of, if I can get on a soapbox for a little bit, some of our problem in the United States is our healthcare is very balkanized. People want to go to the ultimate specialist for any one thing, but then no one's really coordinating your care, and no one knows you at baseline. And that's where sometimes I think people can get into some trouble, shall we say, that they have people who are just treating one particular thing, but not taking the whole patient into account. So.
Yeah, and I think, this came up earlier, Pam mentioned it towards the end of her remarks, but, that what you said, 50% will be irrelevant in 5 years or whatever, like, I read something early on in doing this work that was like, even for someone like you to sort of keep current just in your specialty, like you would have to read nonstop. You couldn't even treat patients, like just to stay with all the meta-analyses, we're just generating such volumes of information in this day and age. Mm-hmm. So I think it's something that we have to, this is where, I always say, like, be respectful, but be firm in advocating for yourself. Like, don't make the doctor the doctor's not your enemy. Oftentimes the doctor's overworked, stressed out, especially these last couple of years has been wild, right? So, but don't take no for an answer if you really think something is wrong. Yeah. And I always say, and this has been a little bit harder during COVID because of the, wanting to keep people from being in big groups, but to the extent that you can have someone go with you if you feel like there's something greatly wrong with you, because that person will hear things you don't hear, You know, if you have somebody, a loved one, a friend with you, if you're really scared something's wrong with you, you may not think to ask a question. You may not hear the doctor properly. So these are all good things. There's also a technique called active listening. So like if the doctor says, I want you to take X, Y, and Z, then you repeat back to the doctor, oh, so you're saying you want me to do X, Y, and Z, and then the doctor can confirm. These are just little tips and tricks around just general patient advocacy that can make us all better healthcare citizens.
Yeah. And your primary care physician will often be your best advocate. And also because if they know you, and they obviously know physicians, and they know what other physicians know, that's what'll help. I've seen, unfortunately, some patients who have kind of wandered around from specialist to specialist, and no one's really kind of trying to coordinate it. And the poor patient is trying to take all of these medical records that really don't make much sense to them and trying to sort it out. And that just doesn't help either. So Pam, were you going to bring up something? I saw that.
Yep. No, I agree 100%. Yeah. Primary care. Yeah.
Well, I mean, I have a couple of younger friends. This one friend of mine who's 30, and he went to City MD for something, then I went to City MD, and I said to him, I was like, and he has insurance. I said, you need a primary care doctor.
Yeah.
You need somebody who knows you, because he was terrified he had COVID in September, and I think he had RSV because we had a huge outbreak of RSV in New York back. My nephew got it, my brother got it, my sister-in-law got it. Chris and I somehow did not get it. I think we might have better gut immunity. Something saved us. But and the situation was he went in, they tested him for strep, tested him for COVID. He was negative for both, and they gave him antibiotics. And I said, you don't need antibiotics. You have a virus, son. Like, you just got to go to bed. But for me and Chris, we've been going to we have the same primary care doctor for, I think, 17 years. So also, like, when he tells us you should get vaccinated for something, we trust him.
Yeah.
You know what I'm saying? Like, he's not gonna steer us wrong. Not that he couldn't be wrong himself, but he would not intentionally, like, he's giving us his best advice.
Yep.
And I think that's critical to have somebody you trust that way.
Yep.
Well, we're actually over time, Vincent, Pam. So thank you everyone for attending. Thank you so much, Vince, for doing this. We really, really appreciate it. Thank you, Pam, for sharing your story and your insights, because it's really critical. And thank you again to Ferring for sponsoring all this. We will be back in 2022 with a new webinar series, TBD. Everybody, happy holidays to everybody. Vince, I hope to see you in person at some point in 2022.
We'll have to meet somewhere.
Same with you, Pam. All right, I'll talk to you guys soon. Have a great day.
Take care. Good seeing you guys. Bye.
Thank you.
Bye.